Inflammation is a term that shows up everywhere in medicine, and several common lab tests are designed to measure it. CRP. High sensitivity CRP, also called HS-CRP, and erythrocyte sedimentation rate, or ESR. These tests are ordered all the time, but the differences between them aren't always obvious. In this video, we'll go over what each marker is actually measuring, how they behave differently, and when each test is most useful. If you enjoy clear, evidence-based explanations of medical topics, make sure to like and subscribe. This content is for education only, not medical advice, so always review your personal health decisions with your physician. Now let's walk through these inflammatory markers. CRP, HS-CRP, and ESR are all designed to help answer a similar question: is inflammation present? But they approach that question in different ways, which is why understanding their differences is so helpful. CRP stands for C-reactive protein. It's a protein made by your liver in response to inflammatory signals. It directly reflects the body's acute phase immune response. CRP tends to rise quickly when inflammation develops, and it often falls quickly as inflammation improves. Think of CRP as a dynamic signal of what the body is doing right now. High-sensitivity CRP, HS-CRP, is not a different molecule. It's the same CRP, just measured with a more sensitive test. Standard CRP is designed to detect big spikes in inflammation, like infection or significant acute illness. HS-CRP detects small elevations that are especially useful in cardiovascular risk evaluation. So when you're evaluating cardiovascular risk, HS-CRP is the version that matters. ESR stands for erythrocyte sedimentation rate. ESR is an indirect marker of inflammation. Instead of measuring an inflammatory protein, it measures how quickly red blood cells settle in a vertical tube of blood. So why does inflammation change how fast cells fall? During inflammation, the liver produces proteins, especially fibrinogen. These proteins change how red blood cells interact, causing them to stack together in formations called rouleaux, which look like stacks of coins. Those stacks are heavier, so they fall faster, and that makes the ESR number higher. Here's a simple analogy. When there's no inflammation, red blood cells fall slowly, like light, fluffy snow drifting down. With inflammation present, proteins cause cells to clump into heavy stacks, and those sink much faster. That settling speed is what ESR measures. CRP rises rapidly, often within 4 to 6 hours of an inflammatory stimulus, peaks at 36 to 72 hours. CRP is broken down quickly in your bloodstream, so it only lasts about 18 to 24 hours. So it will go down quickly as the underlying cause is treated. ESR typically begins to rise within 24 to 48 hours of the onset of inflammation and decreases slowly over weeks or months as the underlying inflammation resolves, often lagging behind clinical improvement. In many clinical situations, especially acute inflammation, CRP is generally preferred over ESR. CRP responds faster, is more sensitive for acute changes, and has fewer confounding factors. ESR can still be useful, but it can be influenced by things like age, anemia, red blood cell characteristics, and plasma proteins like immunoglobulins, which can make it harder to interpret. A common question is, should we just order CRP and ESR together? In routine practice, joint measurement is often unnecessary. Large clinical studies show they don't always agree. One large study of hospitalized patients found the two markers disagreed in about 1/3 of cases. Most commonly, an elevated ESR with a normal CRP, often due to resolving inflammation or confounding factors affecting ESR. So in many situations where inflammatory disease is suspected, CRP is typically the priority test. There are important exceptions where ordering both ESR and CRP can be valuable, especially in certain rheumatologic conditions. Two big ones are PMR and GCA. CRP is almost always elevated in untreated PMR, but ESR can occasionally be low, and in GCA, it's uncommon for both ESR and CRP to be normal at diagnosis. In these conditions, the combination can provide complementary information. CRP often reflects acute inflammation more directly, while ESR may capture broader disease activity influenced by plasma proteins. Systemic lupus erythematosus adds another key nuance. During lupus flares, many patients do not mount a strong CRP response, but ESR often rises. That's because ESR is strongly influenced by immunoglobulins and other proteins, which tend to be elevated in lupus. So in lupus, ESR may be more useful than CRP for monitoring disease activity. On the other hand, a significant CRP rise in lupus may raise concern for infection, and very high CRP levels can suggest a superimposed bacterial infection, rather than lupus flare alone. HS-CRP plays a different role. It's not primarily used to diagnose inflammatory disease. It's used to assess cardiovascular risk. Because heart disease isn't only about plaque amount, it's also about plaque biology and inflammation. HS-CRP helps capture that inflammatory signal. For cardiovascular risk assessment, HS-CRP is commonly interpreted like this: less than 1, lower risk; 1 to 3, moderate risk; above 3, higher risk. And remember, this is a risk marker, not a diagnosis. It needs to be interpreted in context. So what inflammatory labs do you actually need? For most acute inflammatory questions, CRP. For cardiovascular risk evaluation, HS-CRP. For certain rheumatologic conditions, sometimes both CRP and ESR. And in lupus, ESR is often more useful for tracking disease activity, while CRP may point more toward infection. The right test depends on the clinical question you're trying to answer. Inflammatory markers are powerful tools when their differences are understood. If you found this helpful, like and subscribe and check out more of our videos for clear, practical guidance on understanding your labs and your health.